Hello and welcome to today's Hospice News webinar sponsored by KanTime. My name is Jim Parker. I'm editor of Hospice News, and our program today is about demystifying deprescribing, which is often a complex and sensitive set of decisions that need to be made when a patient enters hospice. Before we begin, I'd like to cover a few housekeeping items. First, your lines have been muted for sound quality. Also, a recording of the webinar will be emailed along with the slides following the presentation. We may have time at the end for audience questions. Please feel free to submit your questions using the designated box on the GoToWebinar app. Speaking today is Maria Wharton, Senior Clinical Content Specialist for Home Care Pulse, Wendy Colvin, Senior Clinical Content Writer for Home Care Pulse, David Bougher, Clinical Education and Regulatory Specialist for WISE Hospice Options, and Greg Lotz, Director of Partner Contract and EVV Management for KanTime. Thank you all for being here today.
Thank you.
Thanks, Jim.
Thanks, Jim.
Excellent. So without further delay, I'll let you take it away, and I look forward to hearing your insights.
Hey, I think that's me. I think I'm first. So we're going to go through this by answering a couple questions that we all agreed on. The first one is, what is the best strategy for beginning the discussions about deprescribing with the patient and family? So deprescribing is a great clinical topic, and if you're listening and not in a direct clinical role, I hope that you can still share this discussion with your teammates, and maybe others can gain some value today from our dialogue. There's many tools available to use to train hospice and palliative care clinicians how to have a stepwise process for promoting deprescribing. Giving some clinicians a guidebook or a tool can certainly be very useful for training and just building that ongoing clinician confidence to start conversations. Depends on whether you're type A like me or not, but some people need a tool. If you've ever oriented an employee to hospice who has no background in palliative medicine, you understand that hospice itself can be very difficult to teach to some folks. So I think the most simple answer to that question is, regardless of what tool you use, start the conversation. Talk about deprescribing immediately to patients and families. Everyone has seen a medication list on a patient during an interdisciplinary team meeting and held your breath because it's huge. How could that nurse not have called the physician to ask for medication changes? Why didn't she talk to the patient yet about discontinuing some of those? What is she thinking? Clinicians need to be honest and say during the admission and ongoing, part of my role is to work with your provider to really make sure that you have exactly what you need in place, and you may not need some of the medications that you've been taking. You have to take all of the team players into account in this process too. Can the patient participate? Does the patient want to participate? Does the patient want certain family members involved? Does the provider need to assist in the actual physical conversation? Should there be a family meeting scheduled just to discuss deprescribing? All of those factors need to be taken into account. When you start these conversations, your job as a clinician of any role really on the hospice team is to build trust. You have to constantly remind the patient and the caregivers that the team is never going to bring harm or stress during the end of life. It's never going to be the goal. The intentions are always meant to be positive. Those are things to bring up. Keep using that in your discussions about deprescribing. Next, we have a particular tool that Maria is going to explain to you guys that we all sort of agreed upon as our current best practice that we all like the most. So Maria, if you want to answer that second question, we can keep moving.
Thanks. Thank you, Wendy. So deprescribing, you know, what is it and why is it important in hospice and palliative care? So patients come to hospice, 6 months or less prognosis if the disease follows its usual course. And they may come with medications that they've been taking for decades, or things that they started as part of their treatment for whatever condition has brought them to this point in their life journey. But not all of those things are helpful, and some are even harmful. toward the end of life. So when the patient comes on to hospice or palliative care consult even, you want to take a look at their medications and really kind of say, okay, these definitely are not helping, these are definitely hurting, and these are somewhere in the middle. So it's part of your responsibility as a clinician to make sure that, as Wendy said, the patients are receiving the right treatment and not more and not less. So we thought it was good to share this tool. The acronym is FRAME, that can help you plot out your conversation and really develop your skill set in this area. So just to give a little context as to why this is important as well, a recent study looked at 372 patients with a life-limiting illness, and they noticed that the patients taking more medications every day had a lower quality of life and a higher symptom burden. And that was even when they took into consideration how sick the patients were, right? So even if you were sicker, if you had fewer medications, your quality of life was better than somebody who was maybe not as sick as you, but had a lot more medications. So a lot of that poor quality of life that patients complain about can be related to the multiple medications that they're taking. And they might find that when they stop some of those medications, their quality of life improves. So just to give you kind of a little insight to that, a medication that you normally wouldn't think about in terms of deprescribing is a diuretic. And I had a patient who had just like terrible rash and itchy skin, all sorts of creams, everything didn't work. And then he would go visit family, his skin cleared up, and then he'd come back home and it'd all start up again, and tried soaps and lotions and all of that thing. To come to find out, the issue was when he traveled, he would stop taking his diuretics because he would be out and about and he didn't want to have to always find the bathroom. And then when he came home and started them back up again, his skin was a mess. So even at end of life, stopped all his medications, bed confined, not eating, not drinking much. His skin was amazing, the best it had been in years, and he couldn't believe it. And it appeared to be related to his medication. So I offer that as kind of an illustration of why it's important to think about medications actually causing harm for a patient. So what are some of the barriers that as a clinician you're going to face when getting ready to have these conversations with patients? So the first one is clinician confidence. So this is why this type of training is so important. You know, as a clinician going in to talk to a patient and family about why some medications might be causing harm or why they're no longer needed, I need to have confidence in my ability to have that conversation in a sensitive, compassionate, honest way, so that I don't inadvertently, as Wendy said, cause stress. A second barrier is that fear of triggering that distress in the family. What is the meaning behind discontinuing familiar medications? My doctor told me I would have a stroke and die if I didn't take my medication. I've been taking insulin for decades. How can I not take that medication? So as much as providers struggle with getting patients to comply with their medication, there are many patients equally who are very attached to those medications, and trying to stop those at end of life is attached to, you know, health and longevity and trust in that relationship with that physician that they've had. So that, speaking of trust, is not only the trust with their prescribing physician, but also the trust that they're developing with their hospice and palliative care provider, right? So you come in, you've just met the patient and family. If it's an all too common hospice experience where you have the patient on service for days, maybe a week or two, it's very difficult to build that level of trust that you can have conversations about why those dementia meds need to be stopped or those Parkinson meds need to be stopped. So the fear of impacting that trust is strong in the clinicians. So again, that's why trainings like this are important, because the research shows us that when those deprescribing conversations are done well, that trusting relationship between the patient and the team remains intact, and the patient is going to have the quality of life that they deserve and want. So before you start to have that discussion using that frame work that we'll talk about in just a minute, you have to do some preparation work. So you have to look at what medications the patient is taking and which ones should be considered for deprescribing. And if they have a ton of meds that need to be deprescribed, prioritizing some of those is going to help you out, because it's not so common that patients are going to say, yeah, just stop everything, just keep me comfortable. They're going to have some attachment to some of those medications. So you want to look at the medications where the benefits no longer outweigh the risks. So are they on oral hypoglycemic meds, and now their intake is changing? So have pie and don't take your glipizide is much safer than taking your glipizide and not eating and having a hypoglycemic event. Anticoagulants are another one that are hard. So if you have a patient who has had a pulmonary embolus or DVT or any other kind of clotting, and they've been on that anticoagulant and they know what it feels like to have those clots, they're going to be really reluctant to give those up. But when they fall and hit their head, they're going to have a bleed, right? So you have to be able to have that conversation about balancing those benefits and burdens. You also want to pay special attention to medications that are impacted by kidney and liver function, because we know those organs function differently and less effectively at end of life. So you don't want to end up with situations where patients are having toxicity from medications because of that. A second class that you want to consider is when the time to benefit is going to exceed their prognosis. Gerontologist I worked with, she said those are the 10-year drugs. Those are your statins, your things like that help give you longevity, but aren't helping tomorrow, right? So those are the medications that are not helping the patient at this much anymore, may or may not be causing harm. Statins, if your liver is not working so great, are difficult. But you want to look at those. And then you want to look at medications where that treatment doesn't align with the patient's goals of care any longer. So sometimes that, if they've been on hormone replacement for prostate cancer, gets them all sweaty and irritable, it's not making a difference in their outcome any longer. Those medications can be stopped. Gleevec is one. Tarceva can cause terrible itching. And if your goal is really comfort and maximizing your quality of life for the time that you have left with your lung cancer, then Tarceva is not your friend. Your renal medications, when the goal is to discontinue dialysis, then you can really simplify that patient's medication regime. So let's think about how we're going to use that FRAME acronym to have the conversation. So F is for fortifying trust. You have to build a relationship with that patient, that family, that physician, prescriber, which can be super challenging, as we talked about a minute ago, if the patient's time with your hospice is short. So it's important that your clinicians who are having these conversations are skilled in listening and having a good conversation. You want to start with identifying the patient and caregiver concern around the number of medications that they're taking. Tell me what medicines you're taking. Do you feel like you're taking too many? Do you feel like it's a lot? It's no big deal. Comes across to the patient and family much better than saying all your dementia meds and all your Parkinson's meds, all of those will be discontinued because you're on hospice now and you don't need those anymore, right? That doesn't feel like a validating discussion, and it cuts out any room for that patient and family to have a difference of opinion with you on that. Okay, so next is R for recognize the patient's willingness to deprescribing or barriers to it, right? So sometimes you go in to have the conversation, you get this far into it and this is just not going to go anywhere. So time to table that for another day. Some techniques you can use to find that out is make sure that you use open-ended questions. Those are going to be key to success here. As I was saying, do you feel like you're taking too many meds, too little, just the right amount? Are some of your medications hard to take? You know, the thyroid you have to take, you have to not eat for a while, you wake up, you're hungry. How do you manage that? Some of those potassium supplements are tough. Which ones are giving the patient a difficult time? Those are the ones they may be more likely to stop. And so you get a win in the beginning, and then you can build that trust relationship with them. The most important thing in having these conversations is listening. Listen to what the patient is saying, listen to what the family is saying. Are you picking up any barriers? Are you picking up willingness for certain medications? What do you need to address in that? You know, the patient has dementia, he's been on Aricept for years. The daughter is very resistant to discontinuing that. You need to listen and explore why. You know, dad started taking that 10 years ago. He was so agitated, we stopped it. He was violent. You know, so how are you going to address those concerns as you're deprescribing medications that really are not helpful and might be causing harm at this point? And how do you reassure that family member that you'll be there to help manage any unintended symptoms of discontinuing a medication? Then you need to be prepared to discuss the benefits versus burdens when questions arise. So the anticoagulants are a big one because as patients get unsteady and weaker towards the end of life, we know there's an increase in the number of falls. So if that patient is on an anticoagulant, the risk of them hitting their head and having a significant brain bleed outweighs the risk of the clot at this point in time. And then it helps to listen to what they think about that. They're going to maybe have questions about, well, what happens if he gets a clot then when you stop his medications? So be prepared and, you know, validate those questions, honor those concerns. And then if they're willing to say, you know, okay, I can see those multivitamins are big and they're hard for my dad to swallow, we'll start by stopping those. That's great. You've taken your first step and you want to validate to that patient and that family that that's a good path to be on, and then we'll continue to pursue that in subsequent visits. So next comes A for align. You want to align your deprescribing recommendations to goals of care. So what's going on with that patient and family? Do they have a significant family event coming up? They want to be able to get together for Christmas and enjoy their grandkids, or there's a wedding or something like that. Then you want to look at the medications and say which ones might help them have a little more energy over the next few weeks until that big event, which ones are more likely to cause trouble and give them a more rapid decline if they keep on them, and have those conversations and help them sort through that. Are there medications that you might stop that are causing some confusion or fatigue? And if you stop them, it's going to improve their quality of life and allow them to be more interactive with family and friends, or to complete a task or a event that they want to attend. Are there medications they're taking that are significantly impacting their quality of life? So if the patient's focus, again, is that quality of time, if the medications are making them itchy or constipated or diarrhea or poor sleep, those are medications you want to address first. You know, you tell me that you're too tired to spend time with your grandchildren because the itching makes it so hard for you to sleep at night. What do you think if I speak with your physician about your captopril? That medication can cause itching and your blood pressure is trending lower now, so I think it would be safe for you to stop it. And then we would monitor your blood pressure closely to make sure that it stays okay. You can see how that's a much more reassuring conversation for that patient and that family than to say, oh, well, you don't need that captopril anymore, we're just going to stop it, right? Because their doctor has been hammering on them the whole time the importance of taking those medications as prescribed. Okay, then M is for what is called managing cognitive dissonance. So all our life, we don't feel well, we go to the doctor, we get medicine, they help us feel better, and we continue on, right? So medications are designed to help me feel better, to help me live longer. So what does it mean if I stop them? Does that mean that I'm giving up on fighting my cancer? I'm giving up on being with my family and my friends? If I decide to stop my mom's Alzheimer's medication like you're recommending, I feel like that might cause harm to her, even when I agree that it's important, because if she gets so agitated again, that's not my mom, and she would not want to be like that, and she would not want me to change a medication that would make her be like that. So there's an understanding all of that, struggle that the patient or the family has with deciding to discontinue medications. So when you have the conversations, you can have a very direct approach, right? Because you've built some relationship and some trust with that patient and family. You can say, I'm worried that taking so many medications is hurting more than helping. I want to help reduce the number of medications to something that's a little bit more manageable and safer for you. When it's appropriate, you can include concern and emotions as well. I'm worried about your falling. Your Xarelto slows your ability for your blood to clot, and you can have a significant bleed in your head if you fall, and I don't want that for you. So that helps the patient and the family understand your concern for them, your desire to prevent harm, and as well as your skill in identifying which medications are hurting more than they're helping. And then our last letter and frame is E, which is to empower patients and caregivers to continue the conversation. As Jim said at the beginning, this is a topic that requires a lot of attention and training. It's not a one and done thing. It's setting a stage and building a relationship and then moving forward from there. So you want to encourage your patients to continue to talk with you about deprescribing. So maybe you can ask them to keep a list of questions about their medicines that between my visit today and when I come at the end of the week. Write down any changes that you feel or you notice in your loved one now that we stopped his Xarelto. What have you seen anything different? What do you do if you notice something alarming? Who do you reach out and call so that the family feels supported as we transition through changes in the medications? And let's remind them that this topic is something we're going to talk about throughout our journey together, because what medication is appropriate today may not be so helpful a week or two from now. So we're always going to talk about it. And as a clinician, I'm always going to be open to having discussion with you about any concerns you have about your medications or any part of your care, right? So we're going to talk about making sure we have all of those elements in our discussion. So what is the patient or the caregiver, family member's perception of that medication use versus burden? They may be perfectly fine with taking 20 medications. And that's important to know. If it's not feeling like a burden to them, then your deprescribing conversation is going to take a little bit more time than if they're just like, I'm done with all these medicines, help me just sort it out, right? Making sure they understand why a medication is being considered for discontinuation. Is it because it's not needed, like all their multivitamins, or is it because it has the potential for causing harm at this point in their life? You're going to teach them what to expect to the best that you can when that medication is discontinued, and again, reiterate the follow-up and support that's available to them. As you can imagine, that benefits versus burden conversation is a little bit different when you're talking about deprescribing medications that are not doing anything, like multivitamins, versus medications that can be doing harm, like maybe staying on their insulin or their anticoagulants. So I'm going to turn this part of the frame discussion back to Wendy to talk a little bit about the benefits and burdens conversation. Wendy? I think I have.
All right,
Oh, there it is.
frozen.
Okay.
Yeah, absolutely. I think the frame is just a great tool to keep you on track, and Maria gave some great examples. Every medication is going to hold some level of importance to the patient and be difficult to discuss. You may have a harder time getting rid of that multivitamin than you do the blood thinner. There's patients that are going to say to you, I've been on this metformin for my diabetes for years, I'm not going to stop it. Or they'll say, yeah, sure, here's the bottle, throw it away. It's really specific to that patient and that family. It's a role of just constant education, reinforcement, and reassurance. Maria said, it's not one and done. It's not. It takes work, and it's nothing that you can avoid. Making recommendations with the provider, it's all about eventually getting to that perfect comfort level of the patient, and you do that all the time in hospice. It's shared decision making. It's always, deprescribing is just part of that entire process. The entire team has to agree on the treatment goals in hospice, and the patient and caregivers are part of that. Again, leave that piece of paper and have them write down their questions. Have them constantly plan family meetings until everybody has the goals in line, knows what the plan is going to be. David or Greg, do you have anything that you wanted to add to either the frame tool or just the benefit versus burden before we go on to the next challenges?
No, you've covered it well.
So the next question that just kind of falls in line with a lot of this that we came up with is, what challenges do hospice and palliative care clinicians typically experience during the deprescribing process? And again, we've hit on a lot of these already, but I think the main one is just that clinicians naturally are labeling their patients as psychologically attached to certain medications, because they are, right? Not all the time, but frequently. So maybe the clinicians don't want to feel like they're the source of more psychological trauma at the end of life by taking away something else that's routine from the patient. End of life, there is no routine. You lose all of your routine. That skill to promote comfort medication use and decrease that overall pill burden just may not be something that every clinician in your agency is really comfortable advocating for. And that's where frame and similar tools really can be helpful. Clinicians just may be fearful that they're going to bring that stress and completely destroy that trust. Like Maria said, the first part of frame is to fortify trust. The funny thing is that when you look up most of the research points, patients themselves are actually nervous about their own polypharmacy and more often more open to discontinuation than clinicians assume. So don't assume. Again, start that conversation and keep talking about it. In some circumstances too, especially with hospice, it depends how your referrals are and where you get people in that continuum of end of life, but maybe you don't feel like you have enough time to advocate for deprescribing, depending on that patient's status, so it just becomes unaddressed, or I'll do it next time I go, and then next time it's too late. So you need to be comfortable and confident to have the conversations about deprescribing at any time. Make the time for it. Clinicians may also be apprehensive to recognize polypharmacy and approach providers about formulating that plan for deprescribing. Maybe they're intimidated to change the existing medication routine. Hey doc, I don't like all the meds that you have my patient taking. And clearly be nicer about it, but you have to be an advocate. The providers have that ultimate decision, but again, they're on your team, they're on your side. Don't be afraid to talk to the providers, because maybe they have a good reason why they're not deprescribing. Ask them to teach you, to explain it to you, so you can then go back to that patient and family and explain it. Maybe there's a reason why that patient is still on it. Again, it takes a village. It's the entire team. And that kind of leads us into the next piece for David. If I want to go to the next slide. Jim, can you go to question 4? Thank you.
Thanks, Wendy. Well, this is usually a slide that the question raises quite a bit of angst among us clinicians, because we know that this sometimes is a very fraught conversation. And there's a fair amount of barriers to this as well. One of the things I want to make sure you're aware of, there is no fixed script for approaching this. There just isn't. It's going to depend on the physician and a variety of factors. Over my career, I've realized that approaching physicians about adding a medication or deprescribing a medication, you have under 5 minutes to make your case, and many times less than that, because they're usually quite busy with their own practice and other things that are going on. You also have to keep in mind the gatekeepers. Is there a receptionist going through, a nurse, an NP? So there's a variety of things that way. But with that being said, if you want to and feel it's important to deprescribe for your patient, you do need to speak with the patient's attending physician. So keep in mind that your approach needs to be with courteous confidence. You do need to have confidence in yourself with this. And I think both Wendy and Maria alluded to that in their discussion. You really, really, really need to be prepared for this so that you're not just having looked at a patient's med list and make a phone call to the physician, because you're not going to be prepared for it. And as you've heard us say almost with each question, trust is the basis for everything we do. And the trust has to be developed with that physician that you're going to work with. But I'm going to say something else. I think you have to have trust in yourself, your clinical abilities. So don't discount your trusting in your own skills that are out there. So when you're approaching the physician with confidence, you're not arrogant, but neither are you meek or apologetic. You are an advocate for the patient you're caring for, and realizing that this is a patient for this physician as well, and could be a patient this physician has cared for 40 or 50 years in many cases. Also, your tone and your demeanor are important as well. You don't have the advantage under most circumstances to be face-to-face physically. You're usually on a phone doing this. So your tone of voice and your demeanor and your conversation are important as well. Be prepared. I always think that it's an important aspect of my approach to this is to be, if possible, over-prepared, to anticipate questions and concerns that could come up. At the same time, and this will sound like I'm talking out of both sides of my mouth, you need to be prepared, but you need to be prepared to be concise. So it isn't necessary to go through a long history of this patient. The physician probably knows that better than anybody does. You need to get to the punchline. What is it that you're asking for? And I would say that you want to take a look at the medications that the patient's on, as both Maria and Wendy have said, and you want to prioritize. As you look down through that list, what is the most concerning medications? There's 3 classes of meds when you're looking at these patients. There are those medications that truly manage symptoms. There are those medications that are doing neither good nor harm, such as maybe the multivitamins. And then there are those medicines that are causing harm. Those should be the medicines that are prioritized. So as you look at that, you want to make sure maybe that you get a success out of this and look at the medication that is the most concerning to you as a clinician and make your case for that. You want to be prepared to answer any questions the physician has, which also means there may be a question that comes up that you don't have an answer for, but you need to assure that physician you will find that out as quickly as possible. The other thing with this, maybe a final point to approaching the physician, is to assure him or her that part of your role in doing this is that you're going to follow this patient closely to make sure that no untoward events occur as the deprescribing process goes forward. And we'll talk here in a couple of minutes about whether you just completely stop a medication or you have time to taper the medication and how you're going to follow that. So that's going to be a piece of it. If we were in a different forum, this would be a time we could do some role playing and show some approaches to this. But again, I think it's about trusting your own clinical abilities and your communication skills. Those two things are extremely important. Can we go to the next slide? So what are the typical patient outcomes when we deprescribe? I'm not sure that there's always a typical one. I do think there's a general sense for those of us who've done this for a while that we see in some measure an improvement in quality of life. Be it we've reduced the pill burden, which can be very burdensome. If you look at patients who come to you, if they've come and they live in their private residence, many times they're coming with 9, 12, 14 separate medications a day. If they're coming to you from long-term care, they may have 15 to 20 medications, and that is a lot of medications to take in a day's time. Many times we see a decrease in side effects or adverse events. I've seen a couple of studies in geriatric literature that shows the more medications a patient's on, and this makes perfect sense, the more issues they have with adverse events or side effects. But the thing you may not realize is that in some cases, patients will be on a medication that are causing side effects, and they wind up with 1 or 2 other medications to combat the side effects, rather than having the medication discontinued or changed out for therapeutic equivalent or decreased in dose. So keep in mind that some medications were added to ameliorate the side effects from other medications. And I'm going to give an example of that here at the end of my time. Many times we see an increase in appetite and overall engagement because many instances where the patient is not eating very well, we know that's extremely important to families, or not much engaged in the social life around the family events. Many times those are induced by medications the patient's on. Might see increased safety because there's not lightheadedness and lowers the risk for falls. And as I said, enhanced quality of life is extremely important. So I want to give I'm going to put this as the Reader's Digest version. In March, I was consulted on a patient, 84 years old, with advanced Parkinson's disease. And the short story is she was bedfast, non-communicative, really not eating. When the nurse first saw this patient, she assessed that this patient probably had days to a couple of weeks to live. Really felt this was very much at the end of life. When we looked at the medication, she was on 18 separate medications per day, 7 of them prescribed specifically for her Parkinson's disease. And one of the things the family said initially was they would allow deprescribing of other medications, but they did not want the Parkinsonian drugs to be touched, and yet they were causing the most problems. So go forward several weeks, the hospice team, including the nurse, the social worker, the chaplain, anybody involved, the medical director, were able to begin the deprescribing process for the medications that were causing the most problems. And I got a follow-up from this nurse who said this patient went from 18 medications per day, 7 of them Parkinson's drugs, to 6 medications, and 2 of them being for Parkinson's disease. And the patient was up, walking, eating, engaged, and they were actually considering discharging from the hospice benefit because the patient looked like her prognosis was extended. Now, this is an extreme example, obviously, but it gives a very clear illustration of what outcomes can occur at varying degrees by very appropriate, thoughtful, considerate deprescribing. Maria or Wendy, anything to add to that?
I think absolutely you're right. It's very individualized to the clinician. I mean, you can't say exactly how to advocate, exactly what tools to use. You just got to keep trying and see what works for you. We can talk about frame all day long, but it's really how you interact with that specific patient and family and the caregivers to really determine what am I going to be able to do in the safest amount of time to give that level of comfort.
I think too, David, I think that scenario you shared is so important. You know I've seen that situation happen time and time again, and it's helpful for families, right? This is their first time confronting this kind of a situation and a decision, and to be able to say, I've walked this path with patients and families before, and everyone shares their apprehension and their concern, but I can tell you that the majority of time, what I see is that your loved one is more comfortable, maybe has a little bit more alertness, ability to interact, whatever you're expecting, is really reassuring to those patients and families. So I think that's so important. That was a great scenario to share. Thank you.
We live in a healthcare system that is very geared towards adding medication and therapies, and not much thought or discussion about discontinuing the same things. And if you look, Canada is a big example. They've actually got a national program for deprescribing well before hospice situations appropriately. Things such as antipsychotics that long-term can have some negative benefit, but that's for a different discussion. I like this example. This was one of those that was a very dramatic turnaround for this patient and this family. And the key to this was the teamwork that the hospice IDT and the patient's attending physician were willing to collaborate together to make this occur. So it was great.
Yeah, great example. Again, I used to say it to my hospice staff all the time, but it does take a village. It's everybody working together.
Absolutely. Next slide, please. So what's best to do to stop medications or taper? And that's going to be based on the individual. If you think about the dose of a medication the patient's on and the length of time they've been on that particular medication, that's going to inform how we do this. If it's the lowest dose the medication comes in, probably logically makes sense to discontinue the medication. But if they have been titrated up, maybe to a max dose or close to it, and they've been titrated up over time, this is the big if there's time available, then tapering that medication may be the most prudent way to do this. Again, we don't want to add a side effect or symptom to what's already going on with a patient by discontinuing or tapering a medication. And tapering sometimes gives us the ability to see how they respond, if they're going to have, some increased agitation or behaviors or whatever. I think of the antipsychotic medications. And it gives us a chance to be thoughtful about that and take our time. You think of things like benzodiazepines, those can be dangerous to abruptly stop. So looking at the class of drug, looking at the time the patient's been on that medication, and the dose are always very important to take a look at. The other to take into consideration is what's the patient's prognosis? Do they have days to live? Do they have weeks? Do they have months? Again, it's a guess on our part, but as we saw with the Parkinsonian patient, they had time to discontinue these drugs in a tapering type manner for the most part. So we want to take those kind of things into consideration. So dose of drug, class of drug, length of time on the drug is going to inform whether we just abruptly stop or we taper. Of course, if they're no longer swallowing or alert, that's also going to be a different conversation of how do we get the most essential medications to manage the worst symptoms that are going on. Again, to my colleagues, any further comments on that? Otherwise, I'll turn it over to Greg.
Yeah, thank you, David. I think my experience was trying to help with deprescribing when somebody's on a pretty complicated cardiac regime. I've been a nurse a long time, so a lot of those newer medicines were not things that I had a lot of experience with in the critical care or the hospital setting. So we made sure to work with our consulting pharmacist and with the cardiologist to help us prioritize which ones could be stopped, which ones you had to taper, because a lot of those, if you just stop them, the patient's going to have some pretty significant side effects. So, know what your strengths are and make sure you reach out and use your resources.
That's a very good point. Thanks, Maria.
Yeah, I think that the communication is a huge piece, and that's where, a lot of the different technologies and how your agency is functioning comes into play, which we'll drag Greg into this with that next question, but having an effective way to communicate all of those medications and what the patient is on, how they're responding, that's vital. Everyone in the team has to keep up with all of those details when you're deprescribing.
Excellent dovetail into the next slide. All right, so does technology play a role in managing deprescribing, and what should you look for in a good partner? A lot of things were addressed here: communication, access to data, what have you. We discussed internally with our hospice clinical team how best to respond to this question. What is already covered by this panel discussion, deprescribing is definitely a patient-by-patient decision matrix, and not one that KanTime or any other EMR should attempt to dictate. But there definitely are ways that an effective EMR should assist in facilitating the process, making the information relative to medications on and removed from the active MAR, inclusive of their side effects and interactions, readily accessible for the follow-up visit nurses and the IDT team screens, is key to facilitate an effective review and decision process. The EMR should also support providing a generic user permission for an external patient MD that is configurable to permit access to an appropriately limited list of patients. This then permits the patient MD attendance to the IDT for the deprescribing discussions. Facilitation of care team communication is important as well to ensure everyone is on the same page and working to the same goals. The important thing is that the information should be readily accessible to those that will be making the decision and discussing with the family, patient, and attending MD prior to initiating the resulting deprescribing plan for that individual patient. Information, communication, data accessibility, all covered during the panel discussion, and again, all should be available within the EMR and the technology you're utilizing to assist in managing this process for your patients. Anyone else have anything to add?
Greg, I think that's an essential piece of it. One of the things, and I think the three clinicians on this, we assume that documentation would occur, but that is a key point to deprescribing, is that there's absolutely impeccable documentation, because you want to know what has been discussed, what the outcomes have been, and what direction you need to go. And having that available in the software system is a great thing.
Yes, absolutely critical. You know, when the patient has symptoms, or, you know, it's always the middle of the night or the weekend. And if you're the clinician trying to address that phone call from a distraught patient or family member, you need to know that they just discontinued these 2 meds yesterday, or, you know, I spent an hour trying to convince them that we should look at what maybe is causing more harm, and the family didn't want any part of it. Then I don't want to go in there later the next day and try to hammer them with the same conversation, right? So that documentation, as you said, Greg, and David reiterated, is just key. It has to be there, and it has to be easily accessible, and I have to know where to find it easily.
All right. Do we want to open it up to any Q&A that's being populated from the audience?
Hi, and thank you for that great discussion. A lot of excellent insights. We do have a question that came in from the audience, and I think you subsequently addressed a lot of this point, but just in case there's more to say, I'll put this question out anyway. As a palliative care consultant dealing with non-hospice patients, I find it difficult to speak to patients about unneeded medications, discontinuing unneeded medications when they are not getting the same message from the clinician who is prescribing the medication. Do you have any more tips for this? The primary care providers do not have the same knowledge set as palliative care and hospice clinicians regarding this topic, and we want to avoid giving the patient mixed messages. So you did discuss that a little bit in your presentation. Do you have any other additional thoughts on that question?
I think that that's always a game of education in the community, and absolutely the worst thing you want to do is give mixed messages, and that's hard. That's always kind of a fight, you know, with hospice and palliative, to bring in those community partners to also understand what your goals are. But again, it's over communication. Before that patient or caregiver can have that conversation with that physician, make sure you talk to them and get your medical director, whoever else in the team involved that you need to help in that process to stop that miscommunication before it happens.
Right, that same trust that you work to build with the patient and the family, you also need to build with your clinicians. If you have a partner that you work with a lot, so if you're doing palliative care and you do a lot of work with patients for a particular practice, then there's an advantage of working on that relationship and taking those small steps to help them understand where, you know, you're seeing opportunities for their patient to have a better quality of life, right? Because they're going to struggle from the same things as patients often do, right? If I stop the medication, that means I'm giving up, and I don't want to do that, right? But it's not going to change in a day, and it's not going to change in one conversation. You just have to keep working on that relationship, and always advocating for the patient. So if the patient's really in distress from a medication, then I would push it. I would just be, you know, constantly calling, can I stop by and have a chat, whatever, because you don't want the patient to be suffering because of that. But that's a relationship that you need to really work on to nourish and develop that trust.
Excellent. Well, that was the only question that we had come in. You covered a lot of ground in your presentation, and we really appreciated your being here and sharing your thoughts on this really important topic. I'd also like to thank all of our listeners who tuned in today. Thank you for joining us, and I hope you all take care.
Have a
Happy
great day, everybody.
holidays, everybody.
Have a great day.